Happy Valentine's Day, or Happy Single Awareness Day, or Happy Corporate Made Up Holiday to sell more candy in February. Either way, Valentine's Day sure makes our pancreases work hard. Of course, that's if the pancreas is functioning normally. But we know that's not always the case. In the last sketch, we covered the anti-diabetic agents that boost endogenous insulin by stimulating pancreatic beta cells. But in this sketch, we're going to give the pancreas a break and focus on anti-diabetic agents that lower glucose levels in the body without changing how insulin is handled, by instead changing the way glucose is produced, absorbed, or uptaken. So, welcome inside, and we'll get started. Inside. That reminds me that since we're not affecting insulin, we'll still need to have insulin around. Insulin that's made inside the body, or endogenous insulin. Taking this one step further, needing endogenous insulin around means we're mostly only talking about type 2 diabetes here, as evidenced by the second grade on the board, with one important exception that we'll get into later. First up is metformin, the classic type 2 diabetes drug. Let this metaphor remind you that this table is going to embody all that is metformin. Metformin is an oral agent used to decrease serum glucose by a few poorly understood mechanisms, mostly through modulating the effects of enzymes. Metformin decreases hepatic glucose production, decreases intestinal glucose absorption, and increases peripheral glucose uptake and utilization. Metformin suppresses gluconeogenesis in the liver by inhibiting mitochondrial glycerol 3-phosphate dehydrogenase, or MGPD, the enzyme responsible for getting molecules into the gluconeogenesis pathway. Let this bite out of a mitochondrial candy remind you of metformin's ability to inhibit mitochondrial enzymes. Gluconeogenesis coming to a halt is depicted by her teacher here, putting a hold on consumption of candy from the liver-shaped bag. Metformin also activates another enzyme called AMPK, which also contributes to the reduction in hepatic glucose production. See the AMPK label? Again, the main theme here is that metformin works by modulating the function of enzymes. Besides suppressing gluconeogenesis, metformin also increases the uptake of glucose in peripheral tissues like skeletal muscle and the liver in response to insulin. Put another way, it reduces insulin resistance. The word inside should remind you of endogenous insulin, and there's plenty of candy being put inside that mailbox, just like metformin helps to pull glucose out of the serum and into cells. Think of it as increasing your body's sensitivity to the insulin you're already making. Unless there are clear contraindications, metformin reigns at the top for initial medication in type 2 diabetes. Just like this kid reigns at the top of the class. He's the student of the month, like metformin is the drug of choice. It lowers hemoglobin A1C well and works well in combinations too, if it's not enough on its own. Importantly, metformin does not cause hypoglycemia alone, giving it an advantage over insulin and the oral sulfonylurea agents from the previous sketch. This will be the case for most of the drugs covered in this sketch, but one, as we'll show later, will cause hypoglycemia, so we'll cover that when we get to it. Metformin also promotes modest weight reduction, or at least stabilization, which can be helpful in patients who are overweight or obese. Let's move on to metformin's adverse effects next. Not surprisingly, when you inhibit hepatic gluconeogenesis, lactate is prevented from entering into the gluconeogenesis pathways, causing it to build up in the serum, which can lead to lactic acidosis. So, we've got this spilled and spoiled milk as our recurring lactic acid symbol. The incidence of this is very, very low, but it's often fatal, so metformin carries a black box warning. Most often, this occurs when contraindications have been ignored. Metformin is contraindicated in patients with conditions that predispose them for developing lactic acidosis, including renal failure, heart failure, respiratory failure, liver failure, and significant systemic illnesses like sepsis or shock. Metformin is renally cleared, so dose adjustment is required in renal impairment to prevent that increased risk of lactic acidosis. And since IV contrast used in radiology studies can affect the kidney and prevent clearance of metformin, causing an increased risk of lactic acidosis, metformin should be held at the time of IV contrast administration and for around 48 hours following, for which we've brought in our classic symbol for contrast, the yin-yang sign. Similarly, metformin is withheld at the time of major surgery. Much more common than lactic acidosis are metformin's GI side effects, which include anorexia, nausea and vomiting, and even diarrhea. Wow! Looks like someone's trying to discredit the number one student. Who put that in there? Another important adverse effect to be aware of is that metformin can prevent absorption of B12, also called cobalamin. Clinically speaking, this rarely causes symptoms or anemia, but it is often tested, so it's best to know it. That does it for metformin. On to the next class. Woohoo! Someone wanted her attention. Of course, now the whole class is looking. Thiazolidinediones, besides being lovely to pronounce, are agonists of PPAR gamma, or peroxisome proliferator activated receptor gamma. They end with a glitta zone, which is less hard to pronounce. So we've brought in this fantastic glitta bomb. And boy, do they like to party. Get it? Pee party? Because they are PPAR gamma agonists? Because gamma kind of looks like a Y? This kid knows what I'm talking about. PPAR gamma is a transcription factor involved in the regulation of genes involved in lipid and glucose metabolism. Binding of these meds to PPAR gamma leads to alterations in gene transcription and numerous downstream effects, including increased sensitivity of peripheral tissues like muscle and fat to insulin, so ultimately decreased insulin resistance and decreased glucose release from the liver. They do lower hemoglobin A1C eventually, but because transcription and protein synthesis is being affected, it can take weeks to months to really see an effect from these. That's right. Love your kidneys. You only get 2. Or sometimes 1 if it's a horseshoe. These are definitely not a go-to drug, but they may be useful for patients with renal disease, as most other anti-diabetic agents cannot be used or are less effective in renal impairment. There are 2 thiazolidinediones available in the U.S., rosiglitazone and pioglitazone, but their benefit in diabetes may not always outweigh their associated risks. In fact, rosiglitazone once carried a black box warning for risk of MI, and though this has been reversed in the US, it still has been deregistered in some countries, including Australia and the UK. The whole class carries a black box warning for congestive heart failure and are contraindicated with class 3 and 4 heart failure. This is due to significant fluid retention and peripheral edema, which can significantly exacerbate or cause heart failure. Apart from the weight gain from fluid retention, they also increase total fat mass. You ought to recall that other PPAR molecules are involved in fat metabolism, so that might help you remember that these meds also lead to increased fat cell differentiation and storage of fatty acids, causing caloric weight gain. And finally, they also reduce bone density, causing an increased risk of pathological fractures. Next up is the amylin analog, pramlintide. Amylin is a peptide that is secreted by the pancreatic beta cell along with insulin. Think of it and insulin as synchronized swimmers, rising and falling together. Pramlintide is an amylin agonist, so it slows down gastric emptying, reducing appetite, keeps postprandial glucose at bay, and reduces glucagon secretion. Pay attention here, because this drug is actually indicated for both type 1 and type 2 diabetes. In fact, it's less useful in type 2 since there are other medications with similar effects that we described in the last sketch. It's injected before meals, has a rapid onset, and doesn't last long, making it particularly effective at reducing that postprandial spike in glucose. Pramlintide also helps reduce both hemoglobin A1C and weight. Oh, no, not the candy. Falling candy is our symbol for hypoglycemia. So remember that pramlintide may cause hypoglycemia when combined with insulin in patients with type 1 diabetes. Delayed gastric emptying, like this way too full stomach-shaped beaker, is going to affect the oral absorption of other meds like oral contraceptives and antibiotics, so adjust their dosing by an hour or 2 to avoid this. The delayed gastric emptying can also cause nausea, the most common adverse effect, as well as vomiting and anorexia. All right, on to our next class of oral agents, the SGLT2 inhibitors. He's just got to floss to make sure he looks fly, then he can hand out his kettle corn to the other kiddos. Note that it is not the other kind of flossing, though I wouldn't put it past these second graders, I'm sure they know it. The SGLT2 inhibitors include canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin, drugs with that flozin suffix. They also have gl in there, as in glucose. Together with flow should make you think of flowing glucose, like flowing out in the urine. This is because this newer class of oral antidiabetic agents inhibit the sodium glucose cotransporter 2, which normally very efficiently pulls glucose and sodium back into circulation into the proximal tubule, which you might remember we symbolize with the Procar racetrack symbol. But when inhibited, out they both go, flowing through the urine. Be free, glucose! Be free! These are second or third line drugs for type 2 diabetes, usually added to regimens for patients having trouble achieving glycemic control as an alternative to starting insulin therapy. SGLT2 inhibitors lower hemoglobin A1C and help reduce weight as well. There may also be a beneficial decrease in cardiovascular mortality with these medications. It's unclear why, but it may be from weight loss and or lower blood pressure. Recall that both sodium and glucose are prevented from being reabsorbed by these medications, creating an osmotic gradient, and water follows, causing a relatively significant volume depletion that can lead to orthostatic hypotension and even syncope. So ensuring adequate hydration in your patients on these meds is very important. This is worsened with patients on diuretics, especially loop diuretics. And bacteria and other microbes in the genitourinary tract are in for a sweet surprise with all that glucose coming down the line, putting patients at increased risk for urinary tract infections. So we have our classic UTI symbol, the bladder and ureter-shaped martini glass. Don't worry, kids. It's totally just apple juice. Vaginal candidiasis, for which we have the Canadian flag, and other perineal infections. Because these are acting on the kidney, it should come as no surprise that in patients with renal impairment, they are less effective, and adverse effects are more likely, so renal function should be monitored, and they're contraindicated in renal failure. And to finish up, SGLT2 inhibitors have been associated with diabetic ketoacidosis with risk factors including infection, surgery, and dehydration. Finally, we've reached our final drug for this sketch. We are talking about the alpha-glucosidase inhibitors last, which are acarbose and miglatol. These drugs block alpha-glucosidase, an enzyme that sits on the intestinal brush border and cleaves polysaccharides and disaccharides into monosaccharides. This slows the absorption of glucose since sugars are absorbed as monosaccharides and prevents that glucose spike you can get after a meal. Hey, who took a bite out of my cupcake? I was going to enjoy that one. Because they prevent that glucose spike, they are most useful for type 2 diabetic patients who tend to have high postprandial glucose. They have a modest impact on hemoglobin A1C and fasting glucose levels. At least they left a card with a cupcake? That makes it better, right? Another benefit of these drugs is that they actually appear to reduce the risk of MI and hypertension. It's likely that their effect on postprandial glucose contributes to these cardiovascular benefits. Unfortunately, these can have some pretty embarrassing side effects that, while they're not particularly dangerous, can lead to patients stopping them. Since all that yummy sugar that doesn't get absorbed continues on down into the colon, bacteria go crazy and chew it all up and produce plenty of gas, causing flatulence, diarrhea, and abdominal discomfort for the patient. And it's no surprise that these are contraindicated in patients with intestinal conditions like IBD or malabsorptive conditions. All right, let's sum up this sugar-sweet Valentine's Day. Metformin is the first-line agent for type 2 diabetes treatment. It works by modulating enzymes, specifically mitochondrial GPD and AMPK, to decrease gluconeogenesis and increase peripheral absorption of glucose, which increases the sensitivity of the body to insulin, or put another way, reduces insulin resistance. It is associated with weight loss, which can be beneficial, but is also associated with a rare risk of lactic acidosis, which typically only occurs when metformin is used where there are contraindications present, like kidney, heart, or liver failure, or if it's not stopped for acute conditions, surgery, or when IV contrast is used. Other side effects include GI side effects, as well as low vitamin B12. The thiazolidinediones end in glitazone, which may be easier to remember than their name. These are PPAR gamma agonists that result in increased sensitivity to glucose as well as decreased glucose production in the liver. Because they're transcription cofactors, they take longer to see an effect. A major benefit is that they are useful in patients with renal disease, but they have significant side effects, including weight gain from both fluid retention and increased fat storage. This fluid retention can even cause or exacerbate congestive heart failure. Pramlintide is an amylin analog that slows gastric emptying, which reduces appetite and postprandial glucose spikes and reduces glucagon secretion. It can be used for both type 1 and type 2 diabetes and help reduce both hemoglobin A1C and weight, but can also result in significant hypoglycemia. Its delayed gastric emptying can also cause nausea and affect absorption of other drugs. The SGLT2 inhibitors ending in flozin inhibit the reuptake of glucose from the proximal tubule back into circulation so that glucose, along with sodium, is peed out. These may also help by reducing weight and may have cardiovascular benefits. But because sodium is also lost, hypotension and syncope can also result from osmotic diuresis. And urinary glucose can increase risk of UTIs, vaginal candidiasis, and other perineal infections. They also cause ketoacidosis and should not be used in patients with renal impairment. Finally, the alpha-glucosidase inhibitors, acarbose and miglitol, inhibit the intestinal brush border, breaking down larger polysaccharides into smaller sugars, reducing intestinal absorption of glucose and reducing postprandial glucose spikes. They have few side effects, but because of colonic bacteria digesting more sugars, flatulence, diarrhea, and GI upset can cause patients to stop taking them. Now that you're all up on these sweet anti-diabetic agents, let's go grab some of that candy and spike our serum glucose. Then we can make like the SGLT2 inhibitors and just flow on out of here before they catch us. Okay, but really, I do need to go pee.